Good morning to you all. And as part of the LOC, welcome to AIOC Kochi. I hope you've been having a good time so far. My topic is exudative retinal detachments. And as you know, a myriad number of causes can cause exudative detachment. So in the 7 minutes allotted to me, I'm planning to just tell you a few of the major causes and how you can differentiate one from the other and what you should keep in mind when you see a patient with exudative detachment. And I don't think, like my previous speaker, I also need my pictures. Yeah, it's here. Shall I click? Yeah, as you all know, exudative detachment is when there is no evidence of traction and there is no evidence of a break. And when it is because of the break of the outer blood retinal barrier, fluid seeps in the sensory neural space. And we can have inflammatory etiologies, of which the most common entity that we meet is VKH, tuberculosis. Yes, it's here. Yeah, so we have inflammatory etiologies, VKH, posterior scleritis, tuberculosis in our country, infectious etiology, it will come up in the chart, vascular etiology like Coats disease, sometimes in venous occlusions, vasoproliferative tumors, a lot of tumors like the metastasis, lymphomas, melanomas, and then you have a miscellaneous group where you have the uveal effusion syndrome and the B-dump and other exudative detachments. What is important is your symptoms. A detailed systemic history is very important, and the symptoms are usually floaters if there is vitritis. Otherwise, they may have no symptoms at all except the defective vision. The physical findings will depend on the cause, and the fundus from the differentiation in the RD, it will have a convex configuration, and unlike the rhegmatogenous RD, it will be smooth and not corrugated, and the detached retina is very mobile. Imaging and a lot of investigations will help us case wise, so we will go into the causes. So VKH is a bilateral granulomatous uveitis with exudative RD. It can also have pleocytosis in the CSF, and then later on followed by the skin changes of the vitiligo and poliosis. FA and B scan are the ones that help us more than the classic exudative detachment with shifting fluid. Here we have multiple sensory neural detachments with disc edema and choroidal thickening on B scan, and the classic fluorescein angiographic picture is pinpoint leaks with disc leak. And the management, of course, is aggressive use of corticosteroids in the beginning, but most of these patients will require long-term immunosuppression and slow tapering of the immunosuppression over about 12 months to 18 months. Biologicals sometimes may need to be used if there is multiple recurrences. Posterior scleritis comes in the differential diagnosis. Here, mostly the patient will have pain, and though the fluorescein angiogram remains almost the same, sometimes you may not see any leak at all on the fluorescein angiogram, but then you will find the classic T sign in the B scan. Management, again, you have to find out whether it is infectious or inflammatory, and then depending on that cause, you will need to treat. The other important differential diagnosis of VKH is central serous chorioretinopathy, not the classic one, but the multifocal one, especially the one in which you have the, when it is secondary to steroid use, when you have multiple areas of sensory neural detachment. And the main point of differentiation of multifocal CSCR from VKH is the fluorescein angiogram. Here you will have discrete leaking points, and sometimes you will have large areas of the chorioretinal atrophy, which is the area that is leaking, and so otherwise you will have discrete leaking points and then ends up in pooling. And there will be no choroidal thickening as much as in VKH. There will be no evidence of uveitis. It is very important for us to differentiate the two, because the treatment for a multifocal CSCR would be stopping steroid, and for VKH would be giving high dose of steroid. So this differentiation is very important, and one important the point is that there will be no disc leak in CSCR. How will you treat multifocal CSCR? You can stop the steroids, and you can give focal laser to those leaks if they are away from the fovea, and sometimes drugs like eplerenone can help. Accelerated hypertension is another cause for exudative detachment, and it is basically due to hypertension-induced choroidopathy. And this is a patient who had hypertension-induced choroidopathy, and then the exudative detachments can be seen very clearly. Here also you will get bilateral disc edema, no evidence of uveitis. Pregnancy-induced hypertension produces a very similar picture with exudative detachments, and you can see the FA showing delayed choroidal filling. You can actually see the areas of choroidal non-perfusion. ICG will help, of course, but you cannot do it during that time. The other differential is a uveal effusion syndrome. So now we'll move away from the inflammatory and its differentials to more less common syndromes. Here you have in this unilateral or bilateral choroidal, ciliary and retinal detachment, and it is supposed to be due to a thick sclera, and the treatment is to do a sclerotomy and allow the fluid to drain, and they have a waxing and waning of the SRF. But the classic picture is this thing that you should look for, the leopard spot appearance. So this multiple leopard spot appearance along with an exudative RD, especially on a fluorescent autofluorescence picture, that should ring a bell that it is uveal effusion syndrome. For this you need vortex vein decompression with scleral resection. Metastasis and melanomas. Melanomas less common in our part of the world. Mets are very common. Can also cause exudative detachment, and it is important for us to differentiate it from a primary tumor and for looking for the primary elsewhere. You can see the choroidal undulations and an inferior large elevated lesion here. Choroidal melanomas can also be involved, cause an exudative detachment. Here you can see the melanoma with the exudative detachment. Of course, melanoma has a very classic ultrasound appearance which helps us differentiate Mets from melanomas. And MRI can also help us differentiate melanoma from a Met. I will not go into the details of management. Let me go into this interesting case. 32-year-old lady. She was on investigation for interstitial lung disease. She has been on MMF and systemic steroids because she was a suspected Sjogren's. She presented to us with a 6-6 vision and sensory neural detachments away from the fovea. Left eye also had a similar picture, and AF showed these detachments and some RP changes. Since she was on systemic steroids, we thought that, and the fluorescent did not show a CSR leak, but it did not show a disc leak either. So we didn't think inflammatory. We thought probably steroid-induced CSR with diffuse leak that we are not picking up. ICG showed some areas of hypofluorescence. So we asked them to stop and taper the steroid and stop. 1 month later, the fluid has increased, the choroidal thickening has increased, and the RP changes have also increased. So this time we thought maybe it is related to her Sjogren's and sarcoid. She's having an inflammatory exudative detachment. We asked them to step up the immunosuppression, and MMF was increased, IVMP was given because her vision was dropping drastically. 1 month later, she has 636 and 66. Again, the changes are, in spite of the high immunosuppression, the changes are increasing day by day. The exudative detachment has increased, vision has dropped to 6/60, RP changes are extensive. We had no answer to give her, no treatment. We didn't understand what was going on. There is no evidence of any inflammation. And then finally, a few days later, she presented with severe backache, in which she had bilateral ovarian deposits and a bilateral breast invasive neoplasm. So this is BDUMP, bilateral diffuse uveal melanocytic proliferation, that caused her exudative detachment. So I just want to say that when you have extensive RP changes, that leopard skin appearance and atypical features, we should keep in mind a possibility of a paraneoplastic syndrome. I think I'll not go to the next case because time is up.
First, that was very good, the BDUMP case.
Yes, yeah, but it is relatively rare, so I thought I'll put later.
Audience should have gained more, presented the cases rather than.
True.
Excellent talk, doctor.